after discussing about the etiology and pathophysiology, let's check what laboratory assessment is required in women suffering from hypertensive disorders of pregnancy. So you start off with a complete blood count. Here you can find an increasing hematocrit along with a decrease in platelet count, right? And this all suggests that there is worsening vasoconstriction and a decreased intravascular volume. So the woman is landing in more and more intravascular dehydration, which is reflected as a rise in the hematocrit. So it's always said that a woman with preeclampsia, if her hemoglobin is say 13 or 14, you need not be happy because this hemoglobin does not reflect her actual red blood cell mass. Instead, it's just a manifestation of the fact that there is a decrease in the plasma volume because of the dehydration, and this is the reason why this hemoglobin is falsely high. Okay. Another reason for a decrease in hematocrit can be an ongoing hemolysis in HELLP syndrome. Second, platelet count. I told you thrombocytopenia, it is associated with worsening disease. Next, we go on to the coagulation profile, and this is mostly done when the platelet count is abnormal. It also suggests that there is a microscopic angiopathy that is going on all around the vascular system of the body. It is associated with the worsening of the preeclampsia state. So, after getting a complete blood count, a platelet count, a coagulation profile, we go on with the liver function studies. So, liver function studies, again, AST, ALT, more than 2 times upper limit of normal. Hepatocellular dysfunction is also associated with worsening of disease, and it may even indicate HELLP syndrome or a subcapsular hematoma stretching the Glissen's capsule. Next, amongst the RFTs, serum creatinine, uric acid, 24-hour urinary protein, creatinine clearance. These all would tell you what is the renal function like in cases of preeclampsia. So whenever we talk in pregnancy, we talk about both the mother and the baby. So after the maternal studies come the fetal studies to assess for pregnancy-associated hypertension effects on the fetus. So ideally, you do an ultrasound examination along with color Doppler, where you check for the fetal growth, the fetal weight, the amniotic fluid volume. You suspect IUGR, oligohydramnios, which is suggestive of severe preeclampsia, and you formulate your plan of managing this woman, whether to deliver her or not, and you basically benefit. You want basically would benefit from keeping the baby out, keeping the baby in, and that is the decision which needs to be made at this point, right? Next comes the NST and the biophysical profile and the modified biophysical profile, which tell you the placental status. There's an indirect assessment whether there is any intrauterine hypoxia, what is the danger to the baby if we keep it in utero, or should we induce an iatrogenic prematurity to the baby. So this is the laboratory assessment which we need to do. USG has a different role and a very important place in preeclampsia, whether we are concerned about the maternal ultrasonography or the fetal ultrasonography. So if we talk about the maternal ultrasonography alone, USG abdomen and pelvis, you need to look at the liver in order to diagnose the subcapsular hematoma or hepatomegaly. Second, look at the kidneys to see for any changes in the renal parenchyma, the corticomedullary differentiation, or signs of bilateral renal cortical necrosis, etc. And look for ascites and pleural effusion, which tells you that there is third spacing, there is lots of overvascular hydration and overt vascular hydration, and this again suggests worsening of the preeclampsia. Now, next would be fetal surveillance and placental morphology. So, go for an obstetric USG with color Doppler. Check for one, fetal biometry, amniotic fluid volume. Go for a uterine artery Doppler and an umbilical artery Doppler. It should be performed at the first diagnosis of preeclampsia. So, why fetal biometry? Because when you diagnose preeclampsia, you need to know whether this fetal growth restriction is already kicked in or already set in or not. Second, amniotic fluid volume to know whether the placenta is functioning well or not. Third, the uterine artery Doppler to check for any evidence of uteroplacental insufficiency. And next, the umbilical artery Doppler. So this should be your approach to a woman with preeclampsia. In confirmed preeclampsia in cases of fetal growth restriction, then you need to do a serial scanning for fetal growth AFI, uterine artery, umbilical artery Doppler, all of these. You need to do serial scans. Now, more frequent ultrasound measurements and color Doppler study are needed if there is a high resistance flow or if you diagnose an absent or a reversed end diastolic flow in the uterine artery with appropriate further management. So, in the umbilical artery as well. So, if you find any of these, you know that the baby is the high risk of FGR and impending complications, maybe a sudden intrauterine death, and you follow it up more closely. Next comes the placental location, the placental morphology, because I told you that there is premature aging of the placenta. So you'll do a granum scoring of the placenta, GRANUUM, and see for premature calcifications, etc., which tells you that the uteroplacental insufficiency is quite advanced. And you look for any evidence of placental bed hemorrhage because, again, abruptio placentae or APH is also very common along with preeclampsia. Abnormal adherence, presence of sinusoids, etc. should be documented as well. So again, the role of ultrasound, maternal USG, check for liver, subcapsular hematoma and hepatomegaly, check for signs of renal hypertension, changes in renal parenchyma, look for corticomedullary differentiation, look for cortical necrosis in a woman with PIH, ascites and pleural effusion to check for overt extravascular, overt hydration, right? And next is fetal surveillance and placental morphology, where you check for fetal biometry, AFI, uterine artery Doppler, umbilical artery Doppler. If you find any abnormality, do a serial scanning, and that depends upon the severity of the disease. Look for placental ligation, placental morphology, and check for any retroplacental hemorrhage suggestive of abruptio placenta. So, what are the additional imaging techniques required in certain special circumstances? You need to go in for fundoscopy, especially if the woman is complaining of visual disturbances or scotomata or blurring of vision, etc. So, it is required to differentiate chronic and new onset disease and also to diagnose papilledema or flame-shaped hemorrhages can be seen on a direct ophthalmoscopy. And in order to quantify the prognosis of the woman, you need to take in a fundoscopy examination. Additional imaging, a 2D maternal echo may be required in special situations where the mother is at a higher risk of developing cardiovascular complications. And you will check for the ejection fraction, you will check for the chamber dilatations, and you will check for any valvular regurgitations to quantify her risk for developing cardiovascular complications. Next is a chest X-ray with shield. Now, X-ray may be necessary in situations where you are suspecting an ARDS, an acute respiratory distress syndrome, or there is clinical evidence of pulmonary edema, or in rare circumstances, a pulmonary embolism is suspected. You have to take her up for a chest X-ray with an abdominal sheath. And as I told you, neuroradiological imaging, an MRI or even an NCCT may be necessary for diagnosing eclampsia, cortical venous sinus thrombosis, and a cerebrovascular accident in patients who have either persistent headache, persistent visual disturbances, who are in coma or unconscious, who have recurrent seizures despite adequate anticonvulsant therapy. These are all the indications for taking her up for a neuroradiological